So my name's Ramsey Bowden. I'm a clinical genetics doctor. I work with the adult AT service at Papworth. I've been working there for about a year, so I may have met some of you. And I'm going to tell you today about a study that I'm running looking at cancer in AT. And I know cancer is a really difficult subject for some people, and there may be people who don't want to stay for this talk, and I fully respect that. But I think it's important that we talk about it, and it's important that we research it so that we improve outcomes. So I'm going to take you just a little bit through the introduction of why there is a cancer risk, and then tell you a bit about my study and what we're doing in it. So this has all come out a little bit small, but here I am in red. I'm Ramsey, I'm the clinical geneticist. Some of you will have been seen in the Nottingham clinic, so Manish Suri and Anna Wilsden are the geneticists there. What do clinical geneticists do? Well, we diagnose genetic conditions like AT. We talk to people about the genetics of their condition. We advise on reproductive options, but we also consider the risks of being a carrier and advise on screening and management. And a lot of that is around cancer risk screening. And this isn't a talk about ATM carrier screening, but I know a lot of you will be ATM carriers and will have seen a clinical geneticist about your own risk. And why is that? That's because the ATM gene, as you know, is very important in the repair of DNA, and being able to accurately repair our DNA is important in stopping cancer from developing. So here we see if you have two faulty copies of the gene from birth, that we have an increased risk of developing cancer compared to having one faulty copy, being a carrier, where you need to lose the other copy in most cases to develop cancer. But there are lots of people in the general population who have no faulty copies of ATM at birth, but then may acquire one and then a second, and their cancer will also be lacking in ATM. And that's important because it means that there's a much larger proportion of cancers that are lacking ATM than just for people who have AT. And that makes it an interesting area of research for drug development and other companies to come in and support this. But I think that AT patients are maybe a bit different in what their cancers look like. And there just isn't the data for us to know what cancers in AT patients look like from a genomic basis. So that's what I'm trying to work out. So this is data from Howard's group, from Risha Sharma and the American cohort, of how many cancers they've seen in the population. So in the study of 508 patients, they saw 17% of the individuals with AT had a primary cancer diagnosis. And here you can see in the pie chart the spectrum of the different types of cancers. So most of them were lymphomas, leukemias, and the small light pink portion there were solid cancers. And you can see here in this graph the differences between the pediatric population. So the children have mainly leukemia and lymphoma, and then the adult population, it's about 50% split, whether it's a different solid tumor or leukemia or lymphoma. And then this graph on the far side over here shows the cumulative chance of getting it over time. And there are different colours for the different lines. So the black one is overall with a percentage, and then the age along years. So many people will do well with treatment and survive their cancer and then continue on that line. And for some individuals, as survival is improved, there may be a risk of them getting a second malignancy. So this is why cancer needs to be a really area of active investigation and research, I think, within the AT community. So this is data from Professor Malcolm Taylor on the UK cohort. And I know this words along here are quite small, but we see here, this is done by age and then the different cancer types. Here we see the lymphocytic leukemias and the non-Hodgkin's lymphomas predominantly affecting the pediatric population, but also extending into adulthood. And then here there's a very big spread of solid tumours, increasing in age. And the main ones that we've seen in the UK, it's slightly different to America. We've seen an overlap in upper GI and esophageal cancers, which they have also seen. We've seen more breast cancers than they have, which is also reported in the literature, but we haven't seen the skin cancers that they've seen. So these are small numbers, and there are going to be differences between the different populations. But I think overall it's giving us a better picture of what cancers to be looking out for. And you can see that there are people here up in their 60s with variant AT who are getting these cancers. And so in the variant population as well, we're very aware that this is something that we should be looking for. So why is it difficult to diagnose and treat cancer in AT? You know this. There are a broad range of cancer types, and that makes it hard because we don't know the best way to screen, because we're not just screening for one cancer type. There's not enough evidence about how we should treat cancer when someone does get a cancer, just because there's small numbers, that there are increased toxicities and side effects, and we need better evidence on how we should dose reduce things. And there's a broad and ever increasing range of treatment options. So that's really good that the treatments are coming through thick and fast. And that's why Howard mentioned that following on from this meeting, we're following up with a series of working groups to think on a number of issues around cancer, about cancer screening and about cancer treatment, and how we can make sure that we have the best approach to that going forward. So what are we doing in the UK currently for patients? So there are blood tests performed at all of your routine clinic reviews, which will have, some of them have a role in possibly cancer screening. And then there's breast MRI for women 25 years and over. And we really just talk to people about seeking prompt advice for any concerning symptoms. In terms of management, we know that it's best to modify therapy to reduce side effects. It's very tumour dependent and involves a kind of bespoke discussion with the oncologists, but really we want to be talking to those oncologists, right? So I think that's the message that I want to get out to everyone in the room is, if you do have someone with AT who's diagnosed with cancer, please come and talk to your AT team, and we're happy to liaise with your oncologist and offer advice. So where does my research project fit into this? So we're looking at whole genome sequencing. So this is a way of looking at every single letter in the DNA, and this is the whole genome of a cancer. So it's different, the genome of the cancer, to the genome of the DNA in the rest of your body and the blood, because cancer is a genetic disease, a disease of genetic accumulations. So what we do for patients in this study is we take their DNA from their blood, as long as they don't have a blood cancer, and DNA from a solid tumour, and we compare the mutations to find out what it is in the tumour that looks different. So this is already happening in the NHS for some patients, predominantly children and those with rare tumour types. So some people may have had this through the NHS, but we think that it needs to happen for all AT patients, and that's why I'm running this study. So what do we think we might be able to understand with some of the data from whole genome sequencing? We want to look at the genomic characteristics of these cancers, so the patterns of mutations, to try and understand what causes cancer in people with AT. So is it anomalies in how the DNA is repaired? Is it environmental exposures? Can we see signatures of that? We want to crucially work out how to improve cancer treatments for people with AT. So genomic information can provide a lot of guidance on which drugs and treatments to use in cancer. And can we develop cancer screening tests? So that's a bit of a longer term aim of the project, is thinking going forward, how are we going to get better at developing them, and can genomic information be used to develop screening tests? So the study is called Investigating Hereditary Cancer Predisposition, or IHCAP. It's run under a larger genetic study, and we're offering recruitment to all UK AT patients. So we have about 30 people who've joined the study so far, primarily through the adult clinic at Papworth. The study involves a consent form, providing a blood sample, and then a brief form about family history. And then the study involves giving consent for collection of tissue and tumour samples. So we then go back to any patients who have had cancer and ask their doctors, can you send us the samples, and we can send those for sequencing. So that's the next step, that tumour and germline whole genome sequencing. And then we go on to analyse that data to see if there's anything that we can see about how the cancer developed or how we could treat it. Now, I want to emphasise that at the moment, this is on a research-only basis, and we're not returning results to patients because we just don't have the confidence in what we're doing. We're still exploring the data. But the purpose of this is to build a pipeline so that we can offer you this as a regular clinical service. So I'd love to hear your views on this project. We're running some focus groups to talk to people about what they want to see. So please scan this QR code or come and talk to me. I can give you some information about how to get involved. And I'll be happy to take any questions at the end.